Can you see me okay? I'm really short. So it's just going to be more, maybe like a audio presentation, not a video. I don't know what's happening here. Anyway, so okay, so I'm Srija, the project lead for CISP. I'm sorry, give me 1 second while I get settled in. Yeah, so I wanted to talk about social prescribing. How many of you have heard about social prescribing? Whoa, that's a really, I'm very happy to see that. Like, I was hoping that there will be like no one, like, so I will go into very detail about social prescribing, but really happy to see that all of you know about it already. So, I will start off by sharing some objectives. So we'll talk a little bit about the definition of social prescribing. I'll share a little bit about the impacts that we are seeing for social prescribing on physical and mental health. Is that okay? I think so. Can you hear me? Okay, perfect. And I will wrap it up with sharing the landscape of social prescribing in Canada and globally. So not new, this is not new. We saw this yesterday from Dr. Julian's presentation, but one thing I wanted to highlight back is this report really indicates that social connection can help to serve as a buffer or as a, like even if a preventative approach for a lot of the major health risks that we see. Uh, There you go. Zooming into Toronto, this is from Toronto Star. They also released an article recently highlighting the importance of social connection among focusing on marginalized population. And this paper also states that individuals experiencing homelessness, as well as other stigmatized groups in the community, they need more than just access to food and shelter. They also need to feel like they belong to the community. They also need to feel like they are connected with each other. And this could mean something very small, like just having a meal together or just, giving back to the community. So what was surprising, maybe not that surprising, but what was unfortunate about this report is that the funding for programs like this that are focused on actual engagement with others or building connectedness, especially among communities that are more or less harder to engage with, are the last services to be offered when it comes to, and when it comes to funding shortages, they are the first to be cut off. So, there you go. Looking at the social determinants of health, we also talked about this yesterday. What we see is like our biology and our healthcare only contributes to a small part of our well-being. A lot of it comes from the social determinants of health. But what we often don't connect these determinants of health with our formal healthcare system. And this is where social prescribing walks in to fill in a gap. So what is social prescribing? Simply put, it's the bridging of traditional clinical care system with the social and community supports necessary for well-being. So in a nutshell, it's a way to connect the formal healthcare system and non-medical supports with the goal of addressing social and structural determinants of health. And it's a useful umbrella term for these kind of approaches that connect the clinical with the non-clinical supports and services and provides a common lexicon and framework to help formalize and standardize this type of practice and make it easier and more seamless. The foundational principles of social prescribing are probably not a new concept to you. A lot of you are probably already working with initiatives with this type of connecting like with clinical and non-clinical. But what social prescribing at its fullest can offer, it's an intentional collaboration between health and social care systems, practitioners, and individuals. So it creates a more integrated system and looks at health in a holistic way. And it prioritizes and enables a person's ability to determine their own goals and take control of their own well-being in a supported pathway by asking what matters to you and shifting away from asking what is the matter with you. And then co-creating the solution with the participants. And the social prescribing pathway focuses on tracking these connections and following the outcomes of these interventions in order to address gaps and really to understand the impact that it can create and also build an evidence-informed approach in future. So just to summarize some of the key characteristics of social prescribing is it's person-driven, it's co-creative, it's relational, it focuses on holistic health, it's integrated and evidence-informed. So what process or a pathway do we often see to implement the fullest form of social prescribing for a client? The pathway begins with an individual or a family who is experiencing some non-medical challenges that are affecting their health, who may be disconnected from the support system, but also have unique strengths, gifts, and goals to offer. And their interaction with the health system, like a primary care visit, can then become the door for someone to identify that this individual or this family could benefit from additional support. Although generally what we see is primary care being the initial doorway to social prescribing, it's not really limited to that. And individual social needs can be identified by a secondary care provider or even a pharmacist, or it could be a community member or just a friend who is seeing that someone has some kind of social needs and can benefit from more than just the clinical care. So once someone is identified with a social need, then they can be referred to a community connector or a navigator, or in the UK, who are known as the link workers. And the link worker really plays a key role when it comes to social prescribing and providing social prescribing. They act as the personalized point of contact. They use active listening to sit with the person and talk and focus on really understanding what matters to the person, and then co-producing goals and solutions that mean something to that person, that really connects with that person. They also provide supportive access to culturally and population appropriate resources and help to address barriers and advocate for their clients as needed. And they also empower people to take greater control over their own health. So when they are outside of the social prescribing pathway, when they exit the pathway, they are still independent and they know how to take care of their own health. So some of you were here yesterday at the beginning of our conference, and when we talked about like what connection means to us, one thing that was really like interesting to see was that it really means different things to different people. In our table, we had a really hard time finding that one common point to describe what connection is, and that really makes me think how important it is to make sure that we are really making these social prescriptions person-centered, because we could think connection could mean something, but it could mean completely different thing to the client. So putting the client at the center, making sure that we're understanding them, what they value, what resonates with them, and then building a plan for them with them is really optimizing the best of the situation. So going back to the pathway, after they are connected, so the co-creation happens with the link worker, and once the person is connected to the community, they participate in the social interventions that will improve their overall well-being. And these kind of interventions can look very different depending on the person. It could be just accessing to food and transportation, or it could just be increasing their social connection. It could be focused on self-management of health and behavior change, and many other things. While they participate in these programs, the connector, the link worker, follows up with the individual and checks in until their mutually decided upon goals are accomplished. And the fourth, but definitely not the least important part of social prescribing is the learning. We really make learning a really important piece of the pathway. So throughout the process, evidence and data are collected to track these non-medical interventions to understand the health outcomes of these connections, while looking at the gaps and the ways to improve services, and to be able to demonstrate the impact. So this does require a structured collaboration and information sharing between health and community and social care system. And this is a piece that is really critical for social prescribing initiatives, and also which is what makes it quite unique, is that the ability to collect data and measure the impact of these non-medical supports and services. So we have very promising results, especially from the UK, where the research and evaluation on social prescribing is the most mature. What we see in research is social prescribing has a huge impact on physical, psychological, welfare, spiritual, and definitely on social aspects of well-being. So in one of the Ontario pilot projects of social prescribing, which was implemented within Ontario with the community health centers, what we saw is a 49% decrease in self-reported sense of loneliness and a 12% improvement in mental health over a year of 1 year period. So as well as there are also a lot of really positive impact on physicians' burden and also like frequency to visit the physician and things like that. So we also, okay, so I'm gonna just skip this part because I feel like I'm going over my time. So what's happening globally? Social prescribing is a growing global movement. The term actually emerged from UK, where there are like 3,000 dedicated link workers funded by the national health system, connected in every region, and they are also attached to various parts of their primary care, their acute care, and community services. Rest of the world, we're catching up to UK, and now we have more than 20 countries worldwide who are adopting this terminology, and they're practicing from across different sectors. And on the image here, what you see is what link workers are known as in different parts of the world. So what about Canada? In Canada, we started on this journey of social prescribing in 2018 with the pilot project that I just talked about in the impact slide. And that project really demonstrated success quite early and received a lot of attention from stakeholders in Canada that it started to actually snowball. Midway through the project, British Columbia received funding from their Ministry of Health for 9 demonstrative projects in the region on social prescribing that support older adults. And these early initiatives and their massive success that we saw grown today to projects and active conversations in a number of provinces. And on the map here, what I have highlighted are some of the key players in each of these provinces who are doing really good work on social prescribing. We also had a recent conversation with the Indigenous health leaders on social prescribing, and we have received a lot of positive feedbacks from them. And we will be exploring alignments with Indigenous health and how we can explore social prescribing for Indigenous health. There you go. And Canadian Institute for Social Prescribing, or CISP in short, is the first national level convener of social prescribing in Canada. So we, to help continue to grow these conversations and support emerging practices, the Canadian Red Cross, with support from Public Health Agency of Canada, formed the Canadian Institute for Social Prescribing so that we can have a national hub to connect all people, practices, projects, and research on social prescribing across different sectors and regions together under one big network to learn from each other. And then we can also collaborate and to celebrate what all of us are doing. So so our goal is to connect promising people and practices to share learnings and develop best practices. We're also co-creating a common understanding and framework for social prescribing in Canada. We're focusing on strengthening capacity to working on knowledge mobilization, growing researches, exploring ways to train and build workforce. And last but not least, we're working on building collective momentum in policy and practice. So that's pretty much it. Social prescribing is not a program, it's an approach, and it cannot work in silo. It works in collaboration with all the programs that already exist. It works in collaboration with the clinicians. It works in collaboration with the healthcare. So and if this is something that really sparked your interest, I invite you to join us on this journey. You can visit our website for more resources. You can sign up for our newsletter. And there's also an initiative map where we try to capture all the social prescribing initiatives that are happening in Canada. And we also have a lot of researches that are coming out for social prescribing. We'll try to keep updated through that. You can also share about social prescribing with your teams, community, and networks. You can consider where social prescribing in your services can address isolation and loneliness or enhance human connection. And you can reach out to your region and explore opportunities to collaborate with social prescribing initiatives. So that's pretty much it. I had 2 videos here. I feel like we are kind of out of time. Yeah, so they're just basically talking about their voices from our clinicians and link workers who talk about the impact of social prescribing. And one of the things that really comes up is how much impact it has on isolation and loneliness and creating really connection between people to creating a connected society. So that's all from me.
So hi everyone, thanks Sarija for a great introduction into what social prescribing is. And in order for social prescribing to properly meet the needs of the clients, we have to ask the question, what do they think? What matters to them? And so in our research, that's the focus of it. We're looking at the needs and priorities of older adults with social prescribing, which is a key priority population for this work. We aim to do this through two avenues. The first being quantitative, where we gave an online survey to Canadians across Canada, and then qualitatively, where we invited those with intersectional lived experiences to join us in focus group interviews to go more in depth into our questions. And today I'm just going to highlight two important lessons we learned, and I hope it's interesting for all of you. So in the survey, we asked them to rate their levels of agreement with different statements around social prescribing, and I've ranked them here from the most agreed at the top to least agreed on the bottom, and I want to highlight that difference between the ones that were most agreed compared to the least agreed. So older adults were more likely to agree with statements that suggested social prescribing would help people overall. For instance, social prescribing would help connect people and communities. But in contrast, they were less likely to agree with statements that suggested it would help themselves. For instance, I would benefit from participating, or social prescribing seems like it would meet my needs. And I think this really suggests that although there are positive attitudes towards social prescribing, there seems to be this belief that it's going to help someone else more than it's going to help themselves. And in the focus groups, we asked them specifically, would you participate in social prescribing? And we got both yes and no. So for those who were not interested, they often said, at least not at this time, because they felt that they were healthy and independent, and they also felt like their current social connections were really strong, and they felt very fulfilled through them. In contrast, those who were interested in social prescribing, they wanted an additional way to keep their mind and body active and engaged, and there was a strong desire to regain connections and companionship that they feel was lacking in their lives that they once had. We also asked them about what kinds of activities they'd be interested in, and I can't express enough how many different kinds of activities they were interested in, which I think highlights the importance and the priority of social prescribing, which is individualized and person-centered care. In a previous slide, I showed you how there was a difference between the most agreed and least agreed attitudes around social prescribing, but I also want to mention one that was fourth from the bottom, which was relatively more neutral, which was my healthcare provider would probably use social prescribing if they knew about it. And I think this demonstrates a kind of ambiguity when they think about their own provider. They're not so sure if they would actually support them if they were interested in social prescribing. And so that's my nice segue into our second important lesson on the importance of relationships with your healthcare provider. Again, in the survey, we asked them to rate their levels of comfort with different things they might go to their healthcare provider for. And again, I've ranked them from most to least comfortable. And I want to highlight a key difference between the most and least comfortable. So they were more comfortable with things that you would imagine in the traditional realm of the medical field that were often common and routine. So things like measuring your height or blood pressure, and even getting a referral to see a surgeon. But in contrast, they were less comfortable with things that were outside of the medical realm, maybe a little less common to them, such as referrals to see a career counselor, or getting referrals to be a volunteer at a community organization. And these tend to be things more related to your social needs, and thus fall in the realm of social prescribing. So this does suggest that older adults are less comfortable discussing their social needs with their healthcare provider, and I think that it kind of reflects how we're often a little bit more apprehensive to talk about mental health with our provider as well. It's a little more sensitive, you're a little more vulnerable with that, and so it's something we have to consider as we move forward with social prescribing in Canada. But another thing is, I wondered if the comfort level differed by the quality of your relationship with your healthcare provider. And I think it does. In the focus group interviews, we asked them the question specifically, would you be comfortable discussing your non-medical social needs with your healthcare provider? And ultimately, the question they chose to answer was more like, how is your relationship with your healthcare provider? Which I think stems from, at the core, without a good relationship, there can't be any comfort with this discussion, and there really can be no discussion about social prescribing and participation in it. And they really described to me a lot of what makes a good relationship for them, and this can apply to their healthcare provider, but also the link worker. It's just about interpersonal connection. And so there's 4 key criteria. It's a relationship where you feel like the other person has time and space for you. I have a regular doctor that I see at the clinic that I consider my doctor, but he's also very much under a time crunch and time pressure, and so he doesn't ask and I don't tell. A relationship where there's genuine communication and connection from one person to another. I want to be heard. I want to be listened to. I want someone who can check for understanding along the way. I want a meaningful conversation that goes both ways to know that that person held space for me. That's meaningful. A relationship where they feel like they are seen as they are, an individual. My doctor, she makes assumptions about what I'm like at my age, and she's completely wrong. She sees me as an old lady, and I am, but there's more to me than that. I want somebody who would understand my interests and my capabilities, rather than lump me into a group with old people just because we're all old. And the final one is a relationship built on mutual trust and respect, particularly where the provider can respect you to make your own autonomous decisions because it's a life that you're living for yourself. I've seen many doctors in my lifetime, and if somebody were to ask me who is your favorite, there's only one. I assume that all of them pass their exams, are competent, have good intentions. But he was the only one who's ever asked me, what do you think? What do you want? What do you think is best for you in this situation? He didn't always take my point of view, but I felt that I was being included and that I was being valued as a person more than my illness and that he connected with me. So that wraps up my part of the presentation. And I know there's a lot of information from yesterday and today. So if there's only 2 takeaways you take from this one, I hope it's these. First, that older adults are generally interested in social prescribing, but there's a sense that it would help other older adults more than it would help themselves. And I think that without a good relationship with your healthcare provider, it really can't be done, at least not with someone, so either the provider or the link worker. And the second key takeaway is one that I felt came up again and again in the focus groups, and I think it's something participants would have wanted me to share with the world of researchers and healthcare providers, community providers, and beyond, because I know we're being recorded. And that's this. It's to please keep the human in heart in science and healthcare. You know, we work with a huge amount of large data, and there's a lot of power in the numbers. There's specific client populations and health systems that we have to think about and really think through. But there's also an individual and their personal life story that they've lived, and it's very true to their heart, and it's not something to be forgotten. And thank you for listening.
Great. Good morning, everyone. I'm David Kahn. I'm a geriatric psychiatrist. I work at Baycrest in Toronto. And the work I'm going to be talking about this morning is a project of the Canadian Coalition for Seniors' Mental Health, and I'm co-chair of that coalition, which is an interprofessional group that has been functioning now for 20 years. So it's wonderful to be here, to make connections with all of you, and really to hear about the breadth of approaches and creative ideas regarding human connection. It's really just amazing and wonderful. So I bring a kind of a clinical perspective to all of this. And let's see if that's working. Do I have to? I'm not doing it right. I don't think it's working. Oh, that worked. Okay. So, yes, I don't have anything to disclose in terms of conflicts of interest. So our social isolation and loneliness project is funded by a private anonymous foundation. We definitely thank that foundation. And very much aligns the interest of this particular foundation to our mission. And this particular foundation is really interested in social isolation and social connection. And the main goal of the project is to create clinical guidelines. So that's clinical practice guidelines that healthcare providers and social service providers can use in their practices in relation to social isolation and loneliness. And as far as we know, no one anywhere in the world has done this yet. They don't exist. There are clinical guidelines for all sorts of medical conditions and mental health conditions, but so far, we think this is the first. So that's exciting. It's a 2-year project. It ends in March. The guidelines will be released in February. And we're hoping there'll be a phase 2 where we really want to move these guidelines out there into clinical practice to mobilize guidelines. Lots of guidelines can sit on bookshelves, and that's not very useful. You may not be able to see this, but we have a fantastic working group that's been slaving away for the last year and a half to create these guidelines. And we have a mixture of researchers and clinicians working together from coast to coast. And we have a terrific staff as well at the CCSMH. Well, in line with the first introductory comments about loneliness from, I think it's John, is that right? Yes, John. You might be interested in this quote from a psychiatrist many years ago. So Frieda Fromm-Reichmann, who's a German-American psychiatrist, said that there is a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject of loneliness. And thus it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. And then she says that loneliness seems to be such a painful, frightening experience that people will do practically everything to avoid it. Be interesting in our discussions to think about that quote. In the DSM-5, which is the diagnostic Bible of psychiatry and mental health, which is a very thick volume, like I don't know how many pages, maybe 800. There is only one mention of loneliness in the whole gigantic text, and that's under the category of prolonged grief, which does make sense. And you heard Julianne Holt-Lundstad yesterday talking about how social isolation and loneliness are very much a health and medical issue. And how we know, and everyone I'm sure is aware of this, about the strong association between these and all aspects of health, both physical health, mental health, and so on. So it's a critical issue. So our project started out with, of course, a literature review, and then assembling the guideline group. We've carried out 2 national surveys. The first one was asking health and social service providers about this whole issue. And then the second one, which we've just finished recently, we had responses from over 2,000 older adults and asked them about what they thought about this whole issue. And a lot of their responses were very, very similar to actually what Cindy reported just now, how many older adults said that they would be reluctant to talk to their family doctor or other healthcare provider about the issue of isolation and loneliness. So, yeah, of course, there's other aspects to this project in terms of getting them out in the next few months, but the most important thing is the creation of these guidelines. This is just to say that creating clinical guidelines is a very complex process, and there's a science to it, and it's evidence-based wherever there is evidence, and often there isn't great evidence, of course. And we do our best, and hopefully come up with recommendations that are practical and useful for clinicians. So we started out looking at the literature, doing all the things that one usually does. We looked at academic and grey literature, at Canadian and international publications. We particularly looked at recent years, looking at systematic reviews and meta-analyses where they existed. We looked at practice interventions, patient experience studies. There were very few of those. Promising practices, it's more in the grey literature. And then we also looked at screening and assessment tools, because clinicians are going to want to know what's the best way to actually screen for this. And under practice interventions, things that might actually help, they were categorized by our researchers into these. So social facilitation, psychological therapy, so actual psychotherapies like CBT, health and social care provision, such as social prescribing that we've just heard about, befriending, animal-assisted interventions, physical activity, leisure skill development, and technology-based interventions. And our reviews basically said that there's no conclusive recommendations that can be made for certain types of interventions over others. So you can't say there's one intervention that's the treatment or the real intervention for social isolation and loneliness. And that reflects what we've just been hearing about. An individualized approach is critical, a person-centered approach. But there is a lot of evidence that certain things can help. And interventions that appear to be most likely to produce positive outcomes incorporate multimodal, group, and peer components. And then when it came to promising practices, the emphasis here was on patient-centered care, collaborative health and social care, of course, connecting the two, tailored services for diverse populations, and the use of technology in certain circumstances. Not enough in the way of patient experience studies, but 2 common barriers were identified, so difficulties locating and accessing appropriate services, and a lack of personally meaningful and culturally appropriate intervention activities. So lots of challenges and limitations when you're trying to create guidelines based on the evidence, but and one important thing is, are social isolation and loneliness the same thing? Well, no one thinks they are, but people constantly talk about them as though they are. If you look at the literature, it's riddled with a sort of confusion about this, and as a psychiatrist, I would say they are different, and we know that they overlap considerably, but you have a lot of people who are very lonely but not isolated, and the reverse. So that's a challenge because we're trying to come up with evidence-based guidelines, but it's hard to come up with recommendations that differentiate between the two. All the usual challenges with research, variability in outcomes and measurements, and a lack of research regarding the impact on diverse populations of older adults. And I'm delighted to see there's a presentation later this morning on this. So in our actual recommendations, just a couple, just to give you a taste. So for example, assessment in clinical practice. What do you have to consider when you have a client or patient, sitting here and trying to understand their social isolation and loneliness? And, in psychiatry, we always take a biopsychosocial approach. We try to formulate and understand what's going on. For some persons, the roots might be in very early life and poor relationships with parents and others, traumatic events, things that we need to understand in this person when we're trying to help them. And so there's no single prescription. It's really trying to understand that person. So what we say is that a thorough clinical assessment with a patient or client who is socially isolated and or lonely should aim to explore the possible causes and identify any underlying health conditions that may be contributing. And if there is a serious clinical depression or a social anxiety disorder or very poor hearing that hasn't been addressed, then those could be absolutely critical in helping that person, right? So those are the things that a clinician should be thinking about. And then we've said there are key components to be included in the assessment: medical history, social history, mental health, cognitive and behavioral health, screening for substance use, environment and finances, recent life events such as retirement or serious loss or bereavement, lifestyle factors such as physical activity, and then what is their insight and motivation? Because we can offer all sorts of things, but without the motivation, are they going to listen? Are they going to, or do they need help in terms of the issue of motivation? And then when it came to management and interventions, this is a few things that we say: that we strongly emphasize that providers should apply principles of shared decision-making and an individualized approach. We recommend that clinicians identify individuals' interests to determine interventions that may be the best fit, taking into account the individual's culture and recognizing the diversity of older adult populations. And then, as I mentioned earlier, treating underlying conditions. And these are all interventions for which there is some evidence, so we recommend all of them to some degree or another. Social prescribing, coming back to social prescribing, that is one of our stronger recommendations because, there's definitely some research in support of it. We need more research, actually, but social prescribing clearly is an excellent approach, but how widely available is it across Canada or anywhere at this point? So yes, lots of intervention. Psychological therapy. So for people with loneliness specifically, there's some good evidence that CBT, cognitive behavioral approaches, or social skills training can actually help. And coming back to the Surgeon General, he said number 3, mobilizing the health sector. So that's kind of what we're doing with these guidelines. But just to emphasize that there are so many approaches that we're hearing about at this conference that are critically important. And you can have we're focusing more on individuals at the in helping at the individual level, but clearly there are other approaches at a broader level, at a community level, or even at a national level. That may be really important. And finally, just to mention, Kiefer, Card, and Hepburn described in this paper, what's happening around the world. And they say that the federal government in Canada has no strategy or policies to address loneliness specifically, although they do mention that Stats Canada has conducted research and that Quebec has published a strategy during the COVID pandemic. So key points. So prevalence data related to age, gender, and culture are inconsistent. Actually, I left out that slide, but it's definitely true. Strong associations between social isolation, loneliness, and poor health outcomes. There are guidelines will be, as far as we know, the first to address this from a clinical perspective. There are many possible interventions. Individualized approach and shared decision-making are essential. Solutions are possible at the society, community, and individual level, and noting the UK, of course, as a kind of leader in this field. And thanks very much. It's great to be here, and I put up my email in case you're interested in connecting with me. Happy to talk to you about any aspects of this. And if you have any thoughts about how to get these guidelines out into practice, we'd love to hear from you.
Thanks. If we could have our 2 people join David up here, Srija and Cindy. I don't know. Is it on? Yeah. You gotta hold it in a certain way, right? Is that like a pop star or something? Well, thank you for your wonderful presentation. I think one of the things I like to say about social prescribing as I work with both GenWell is it's really a method of doing GenWell, everything we try to teach and motivate through our health promotion work, it's GenWell in the clinic, right? And I think that idea of mobilizing the health sector is really a critical response because A, there's tons of money there in the health sector, right? It's one of our better funded public services, so a source of opportunity. But people trust doctors, right? And largely doctors are important health authorities, and so I think it's really critical on this issue. But a number of your presentations talked about issues in social prescribing and other types of care or other types of issues within health systems. And so I wonder if I could just start the Q&A session with a question that if you could ask one person to do one thing to advance and mobilize the health sector, what would that be? And if I could just get a rapid fire from each of you, and then we'll open it up for questions to the whole group. So anyone want to go first?
So one thing that the healthcare sector could do, or
who is the one person you would get to do something, and what would you ask them to do?
wow.
Or it could be a category of people. So it could be doctors. It could be
Well, I'd actually love to see government take a more active role around this issue and fund it, because if the data is correct, then addressing social isolation and loneliness and maximizing social connection could actually save us money in the long run. So I'd love to see us do more in Canada, and doesn't have to be at the federal level. It could be at the provincial or local levels as well. But I'd love to see politicians actually become educated and realize that greater investment could actually save us money in the long run.
I can go next. I think one thing that's really important is there's evidence. There's evidence that social prescribing is working. There's evidence. There are anecdotes. There are a lot of anecdotes. There are a lot of success stories. So one thing that I think really can make an impact is capturing these success stories and showcasing this, talking about this. Like whoever you see, talk about how social prescribing or these kind of collaborations had made a difference in your life or in your program or things that you're hearing. So like really highlighting the impact, highlighting the success stories is something that I think it's a really important part.
I can say one too, but it's definitely related to what I've seen in the focus group interviews, and there is a world of difference between the person who had a good relationship with their healthcare provider versus one who doesn't. And I know there are constraints. You know, a lot of doctors, for instance, in urban centers, they can only see 1 or 2 issues at a time. They only have 10 minutes. So what can you do in that time? And perhaps they're really tired and busy, so they don't have the space for the empathy. But if they could like reconnect to that part inside them that first got them into medical school and in that direction again, I think that would be really helpful. Because, you know, I have friends who are my age and just entering medicine, and they've lost a lot of that spark and that empathy, and I hope they regain it so they could be great doctors as well. Yeah.
Thank you. Okay, now opening that up to questions. I think those are one of the things that stuck out to me is each of you targeted different levels and had different recommendations, and I think that is very reflective of like the person-centered and how we all bring something to this issue. And so maybe through conversation or questions we can kind of flesh out some more of that experience. I saw you first, so.
I have a question for Monsieur Jia. Would you please explain the friendly calls program with the Red Cross, Canadian Red Cross? And also I'd like to offer myself as I'm a lucky recipient. I get to find out about loneliness myself. So you go first, and with permission of the mediator and Pete, I could add to this.
So friendly calls are really, we call it a sister of social prescribing. So what Friendly Calls is doing is basically it's a Red Cross initiative to make a friendly call to a client to just to get increase the connection and things like that. So yeah, so Friendly Call is one of those success stories that we always talk about when it comes to the impact of social prescribing that it can have on its clients to increase their social connection or to even address their isolation and loneliness. Is that the question? Like, is that what the question was? Am I capturing it right? If I captured your question right?
Yeah, thanks. Hopefully that was. I know we're just a little bit time limited, so we maybe have room for one more question. But I think maybe one thing that's important to distinguish between social prescribing and some of the other things is there's social prescribing, which is that process of linking people to care. But then there are the social prescriptions, which could be almost anything, right? And as kind of recognized by that individual approach. Does anybody else have maybe one more question? Sandy, I'll go to you. Just because you're easiest to get to.
Thank you very much for your presentations. I was very curious. There's a lot of similarity in the feedback, and it sounds to me like there's stigma around loneliness. What do you guys think that we need to do as a society to remind people that we're all lonely? We're all social beings. There's not enough relational aspects in the world we live in now. What is the one thing that we can do maybe as Genwell to universally tell people that loneliness is impacting their health? It seems like people don't even want to face up to it, just like the psychiatrist said.
That's a great question. Because we do see a lot now in the media about it. It's not being neglected. It is being talked about, I think, but everyone seems to have a different perspective on it. So one of the things that I'm intrigued about is the use of social media and the connectivity that we see, that younger people are constantly connected to their friends on their phones, right? And is that connection? I think it is. It's just different. You know, so old people like me think they're not really truly connected, but I think they are. So we have to bear in mind, I think, that there's intergenerational differences in how we perceive connection, and you know, take that into account. But I think public education is really critical, and one of the main recommendations in our guidelines around prevention is actually around extensive training and education, but both of healthcare and social service providers themselves, but also the public. And yeah.
Adding to what you just said, I think culture plays a big role in terms of like looking at what loneliness could even mean to someone. So like really bringing kind of reflecting onto the culture, or even reflecting back to past trauma to understand what loneliness and isolation can mean to a group or an individual, and then really working from there to make sure that when we're talking about here are ways to get connected, is that actually the way to get this group connected, or are we just making some assumptions as to it looks like this is something that works and we're just kind of extrapolating that to that specific group. So like reflecting back to the personal experiences, reflecting onto the culture, the past trauma is something that really can like make a difference.
I'll just add one more thing. I was thinking about it in terms of the analogy to mental health. So often we always, when we say, oh, how are you doing? You say, I'm good, or not bad, but maybe inside you're not feeling that great. And there was always that recommendation. Maybe once in a while you could just let people see a bit of what you are feeling inside. And similarly with social isolation, you could, on occasion, not all the time, say, I've actually been feeling kind of lonely, or haven't been adapting to the city, or I feel like my friends have passed, or they've moved away, and it can start a conversation from one person to another. And even doctors as well, they can mention it as an authority that they perhaps trust, that even them, they feel lonely sometimes, could be really helpful as well.
Thanks so much to our panelists. It was a wonderful presentation. Give them a round of applause.
Okay, thank you, Kiffer and panelists. That was great.